Record to the computer. Okay, it's recording. Okay, good morning, everyone. Thank you for coming out to view Andrew's presentation. It's more of a process than just Andrew presenting, though, so I'll have to outline that for you. First, let me introduce his committee member. We have Dr. Parmentier. I want to say Parmentier, but okay. And she's in the College of Pharmacy. We have two others, Dr. Cooper, who's in Health Sciences, probably not logging in today because she's had personal problems. However, I do get messages from her saying she will try, so she might log in later on. Another committee member who would log in would be Dr. Jimmy Francis. She's at UT San Antonio. So there's really more people involved with Andrew's work than appear at first glance. So the process is Andrew will present. It will take 20 minutes, 25 minutes, depending on other committee members. So if they do log in, then I would have to kick everyone out of this room so that the committee members could deliberate, and I can only do that through a Zoom link. If they don't log in, though, then we can just walk out while everyone's enjoying the food and mulling around. We'll see how that works out. But anyway, we deliberate for about 15, 20 minutes, and then we call Andrew back in, and we talk to him about next steps. So that's the process. Andrew Sanders applied to the Health Sciences program. It's been about a year now when you started the application process. And then he started as a student in the fall semester. We're lucky to have him. He came from an undergraduate program at LeTourneau. And then eventually he got to the Ashbury Theological Seminary. And so he has a graduate degree already. And then he spent a few years, well, more than a few years, working in foster child advocacy in Longview at the East Texas CASA organization. And I think that's where the seed of this idea came from that he's going to present to you today. So it's very exciting. And also, I'm proud to say he's a recipient of an Archer Award. So UT system will send Andrew to Washington, D.C. this summer. And I'm not quite sure how that's going to end up. But if anyone pays for travel to study in Washington, D.C., I think that's a great opportunity. So again, we're very fortunate to have Andrew in our department. And with that, oh, I forgot one other thing. You plan eventually to get a PhD. So this is good practice. And hopefully it's even good data that you might be able to leapfrog into a PhD program. So with no further ado on my end, I'm going to let Andrew begin his presentation. Do you use that? Screen share. And I guess it's this.
Yes. Perfect.
Now, you are allowed to take your mask off.
Okay.
You're presenting.
Good morning, Musharraf. I see that he just logged in.
Good morning, man. How are you doing?
Good. I'm going to get started. Thank
Sure,
you.
sure.
Welcome, and thank you all for being here in person and on Zoom, and maybe even watching this recording later. I am proposing a study to look at the substance use during pregnancy. This will be a mixed methods study using both qualitative and quantitative data. And before we get too far into this presentation, I want to address the elephant in the room. And that is, who are you? Who are you to be studying this? You may be thinking to yourself, why would I, clearly not a woman or pregnant, be interested in this particular topic? Now, as Dr. Sorensen alluded to, I spent quite a bit of time working for and volunteering at East Texas CASA. This is an advocacy program for foster children. I began volunteering with them in 2010, and over the last little bit more than 10 years, at different points, I have been a personal advocate for a few foster children, and then spent 4.5 years or more as the program director for the same program. In that time, I was running our program for 3 counties in 6 county courts, and was involved in hundreds of CPS cases and met thousands of individuals involved in different CPS cases throughout all of the counties. Throughout that time, I saw the system work very well for some folks, and then work very poorly for others, and even I saw the system work against some. One of the groups that really stood out in particular were the women who used substances during pregnancy and had their newborn and themselves test positive for the same substances. When this happened, a report was made to CPS, resulting in the newborn being removed from the NICU or mom's hospital room to have visits only happen once a week, maybe twice a week, until mom had done some drug treatment courses, passed some drug tests, and jumped through a few other hoops. So I started to wonder if the criminalization of women who use substances during pregnancy was warranted. And that's what brought me to my interest in this study and to today's presentation. Our agenda for today's meeting will include a look at the background of the issue that we're talking about here, the purpose of my research, the 2 hypotheses that I have created and that I think I'll find in my research, the methods I'll be using to recruit and actually execute the study, the theory that has informed my research, and the significance to the field of child welfare and other significances of this study. Now, to start, I want to let you know that you'll notice throughout this presentation that I'm not using the word addiction. I've chosen not to use this particular term because of its unclear definition and stigmatizing stigmatizing connotation for those who use substances. Addiction as a diagnosis is self-described or self-prescribed, wherein a person who is in recovery, the first step of recovery is to say, I am an addict. Whereas if someone says you are an addict, that is not helpful to their progress. Instead, we'll be using 4 different levels of substance use categories to define substance use during pregnancy. So you'll see here on this, there's a sliding scale that as substance use during pregnancy increases, so does the substance use category. Now, a definition for each of these is that substance use, the lowest level of substance use during pregnancy, is the recreational and occasional use of substances for mild euphoria, calming effects, or social purposes. In a national survey over a 5-year period, an average of 68% of pregnant respondents admitted to past year substance use, indicating ongoing substance use. In addition, this year, in fact, just last month, a publication found that most women will use medications or substances at some point during their pregnancy. This is not surprising to see. The next level, where an increased substance use happens during pregnancy, we see substance misuse. This is the use of one's own or another's medications or prescriptions for non-prescribed purposes. This would include the self-medication of diagnosable conditions. Moving further still, we reach substance abuse. That's the regular misuse of prescriptions or ongoing use of substances for altered states. And then we reach the farthest point, wherein this arrow just keeps going up here, and this is substance use disorder. This is a clinically diagnosable label wherein a person has substance use without the ability to stop. Treatment is warranted and needed when substance use disorder is found. So, to learn a little bit about the topic of our presentation, we're going to look at the 5 W's. That's the who, what, when, where, and why of substance use during pregnancy. So first, who is affected? Clearly, the newborn, the infant, the developing fetus or embryo is affected by mother's substance use. And we're going to look into the science and biology of why that is happening later, but the primary and first line of impact is the developing fetus. Secondarily is the woman who uses substances, whether she's using substances to treat medical ailments or using substances for high feeling or for other purposes. She is affected by her substance use, especially when it leads to a dependence wherein treatment or detoxification is necessary. Moving out further, we see that the family support system is affected by substance use during pregnancy. When a newborn is removed from a mother's care, often the first line of placement is within kinship placements. These are lateral or parallel lines of the family tree wherein aunt and uncle, grandma and grandpa, or other similar family members are relied upon for the care of a child or newborn when substance use is involved. Moving out further still, we see that the extended community is affected by substance use during pregnancy. This can be the social workers, the court system, hospital staff, and therapists like occupational therapists, speech therapists, and other physical therapists who are involved in the mother's recovery and in helping the newborn reach developmental milestones that would be expected by their age. As you can see, this is clearly a public health issue. Now, we're going to move towards the what. What is substance use during pregnancy? You can see from this list here that it includes many different types of substances. Now, surprisingly, not all of these substances contribute to poor birth outcomes or cause problems with pregnancy. However, researchers have found that polysubstance use is an issue. This is where people will use multiple substances at the same time, and those substances often will work together to cause worse problems than single substance exposure would. That's why this list includes legal and illegal substances, prescribed and unprescribed medications and prescriptions, and even some treatment medications like methadone, which does contribute to birth outcome issues. So we've looked at the who, the what, and now the when. Now, I hope that you're able to see what's going on here. We've got embryonic to fetal development periods, and there are stages of less and highly sensitive periods of development. From this, we can see that if a woman is using substances during week 5 of her pregnancy, while the embryo is being developed, this is the highly sensitive period for 7 highly important stages of development of the embryo. However, if she's using substances during week 32, we've got 4 of the less sensitive periods of development, and as the pregnancy progresses, we've got less and less of the sensitivity to developmental impact because of substance exposure. So a woman using substances early in pregnancy can impact the outcomes of her pregnancy greater than a woman using substances later. Now the where. Where does this happen? We'll note that this is a global issue as well as a local one. For the purposes of this study, I plan to focus on 2 contiguous Texas counties, Gregg and Smith counties. Zooming out a little bit, we see that in the United States, there's been a 5-fold increase in opioid use during pregnancy from 2000 to 2009. Those numbers have continued to increase since that time in the US as well as in Texas. Now, in Texas, drug use affects approximately a rate of 9.4 in every 1,000 births. Now, I want to teach you a little bit of terminology here, and that is neglectful supervision. When CPS, or the Department of Family and Protective Services, removes a child in Texas because of drug use or exposure, there is not legal standing to remove just because of drug exposure. However, they call it neglectful supervision because of the theory that a parent who's using drugs cannot provide as good of supervision as a parent who were sober. So in 2017, Texas saw 71% of the CPS removals for neglectful supervision. Now let's zoom in just a little bit closer on that and look locally. So on this graph, you'll see Texas-wide and Region 4 removals of newborns for neglectful supervision or for drug exposure. And you'll see consistently over 5 years that the light gray area, which is Region 4, these are 23 Northeast Texas counties, including Smith and Gregg counties, consistently removes a higher percentage of newborns because of drug exposure at birth than Texas as a whole. So now we've established the who, what, when, and where. So let's look at the why. Why is this important? Clearly, a person using substances should refrain from use during pregnancy. But what happens when that's difficult? When someone struggles to stop using their substances? Probably you're thinking, well, the first line of defense for that would be her prenatal care appointments. Doctors are mandated reporters, and as are all medical professionals, are mandated reporters, which means they're obligated to report any suspected substance use during pregnancy to child welfare authorities. In a few US states, not in Texas, the courts have the authority to force women into detoxification programs or treatment centers against their will when substance use during pregnancy is detected. This is called civil commitment. Without a clear and effective intervention, women using substances during their pregnancy simply try to avoid detection and hope for good pregnancy outcomes. This study will entail interviewing some local women who use substances during their pregnancy to determine their experiences. We'll look now at the aim of this study. The purpose of this study is to gain a greater understanding of the perceptions, attitudes, and beliefs of women who use substances during their pregnancy, their willingness and ability to seek treatment for substance use and prenatal care during pregnancy, and whether punitive legal consequences affect their willingness to seek regular medical care. I hypothesize that women with substance use during pregnancy will report that a fear of arrest or removal of their child impacted their willingness to participate in prenatal care during periods of substance use, and those same women will report attempts at moderation or abstinence from use when interactions with medical authorities were imminent. As I've mentioned, this is a mixed methods study. I'll be using qualitative or open-ended questions along with quantitative or numbers and data-driven questions. My plan is to interview 20 women found in Gregg and Smith counties. The interviews will take between 1 and 2 hours and will occur at a place of the woman's choosing where she is comfortable. I'll use a 2-layer selection criteria for participants for this study. The first layer will include some criteria such as women who gave birth during the pandemic period, which is quantified as March 2020 or later. Women who use substances during their pregnancy, such as tobacco, alcohol, illicit drugs, or misused over-the-counter drugs and are willing to talk about that substance use during their pregnancy. As I said, residents of Gregg or Smith counties of an adult age and women who speak English well enough to participate in interviews. The second layer of my selection criteria is that I hope to recruit women who are reflective of local demographics. You'll see here a chart of US Census data that shows a breakdown of race and ethnicity markers for our local area. I've used these to average together to determine a loose estimate of how many people would be a very good reflection of our local community if I'm able to recruit them. To recruit my initial participants, I plan to use a flyer that I'll hang in places frequented by women with young children. This could be doctors' offices like pediatricians, CPS offices, Alcoholics or Narcotics Anonymous meeting locations, along with WIC offices and a variety of other places. You'll see that there's a QR code, an email address, and a link to a form that women can fill out for more information about the study. Now, a note about the interview tools. The interview, as I said, will have a 4-part questionnaire. The first will be a quantitative data collection time where I will collect demographic information and basic background information, as well as I'll spend this time building rapport with the participants. The next will be a TAPS tool. This is a clinical assessment wherein I'll be able to gauge current substance use for the women and likelihood of substance use disorder presence in the participants as we go through those questions. The third will be a kinesthetic and visual component wherein I'll use the 2 posters seen here. Women will begin by marking lifetime use of substances in one color, followed by during pregnancy marking of a different color for each substance. And then they'll be presented with the pregnancy timeline, wherein we're going to mark significant points of their pregnancy, periods of substance use or abstinence, and other issues. But I'm going to show an example of that in just one moment. The final section of the interview tool is the qualitative section. I'll be asking open-ended questions to determine the woman's views on motherhood, on their substance use history, and other issues. Questions like, where did you learn to be a mom? Will be asked. Or what do you think are the most important things that mothers do? May be asked. So to better understand, especially the pregnancy timeline, let's look at an example of how an interview may go. You'll see here that a substance use poster has been marked with lifetime use in blue and during pregnancy use in red. So an interview might go something a little bit like this. Please use the orange marker to show when you learned you were pregnant. And what about when you started to show? Okay, and what about when did you deliver? Great. Now with the red marker, let's make a cross when you went to the doctor about your pregnancy. Okay, I went right after I learned I was pregnant, and then one other time before I had my baby. So probably there and there. And then when I had the baby too. Great. Now on the substance use list, you marked that you used tobacco, alcohol, and marijuana during your pregnancy. Let's mark each of those with a different color. Which would you like to start with? Smoking is the easiest. I quit when I learned I was pregnant, so I'll do that in blue. But then I did start smoking again for a while. I had to stop when I started showing because nobody would get cigarettes for me anymore. Then I started back after the hospital. Okay, And what about alcohol? Well, I stopped drinking when I learned I was pregnant. But then one time I got drunk, but only once because I had to go see the doctor the next week, so I didn't do that anymore. You're doing great. The last thing to add here is marijuana. How about we use the green marker for that? Makes sense. I vaped THC for a while when I stopped smoking, but it didn't do much for me, and I didn't feel right about it, so I stopped. I picked it back up after the baby came, though. Now, clearly this is a fictitious example, but from this, you can see just how much data I'll be able to gather from an activity like this. In this, you can see periods of polysubstance use, periods of complete substance abstinence, periods of abstinence before medical appointments, and the impact and times during pregnancy when substance use could have an impact on the developing embryo or fetus. You'll likely notice that these interviews will produce vast amounts of data. I'll combine 3 approaches to analyzing the data. Quantitative data will be analyzed using non-parametric techniques such as the chi-squared and Fisher's exact tests. Audio recordings of interviews will be transcribed and analyzed using the LIWC, or Linguistic Inquiry Word Count analysis, which measures for markers of truthfulness and honesty in conversations. Finally, a graphic content analysis will happen of the posters, as we just saw in the example. My study is based on a proven theory developed in the 1950s to determine the willingness of individuals to engage in medical care. The theoretical framework is called the health belief model. You'll see here, especially in the middle box, that there are 3 key components that, if they are true, women are more likely to seek prenatal care. If women believe that the benefits of prenatal care for their own health and for the health of their developing child exist, they're more likely to seek care. If the barriers to care, such as financial and time costs, are not limiting, they're more likely to seek care. And if the threat of getting caught using substances during pregnancy is outweighed in the women's beliefs by the benefits of prenatal care, then they are more likely to receive care. Below each of the elements of the model, you can see where in the interview I'll be measuring them. So I've got parts 1 and 2, 4 and 3. In the modifying factors, the first box, you'll see that certain elements will affect downstream decision making. For instance, the substance type. If the substance that a woman is using during her pregnancy is cigarettes and over-the-counter medications, then she may be more likely to access prenatal care due to a belief that she will not get caught or will be punished less severely than an intravenous drug user. The other factors listed there may also play a role in the downstream decision making. In the third box, we see outcomes. And this is whether or not women seek prenatal care or seek treatment for their drug use. I believe that the findings in the second box, the individual beliefs, will inform and define the findings that I'll have in the third box. So that brings us to the significance. What is the so what? What's the point of this study and why is it important? I believe that one of the ways that the findings of this study can be important and impactful will be in hospitals and treatment centers locally. I think that by hearing from the voices of women who have used substances during their pregnancy, that medical providers will be able to have more informed and more impactful conversations with women seeking care. Along with this, the legal system, the court system, prosecutors, CPS workers, and judges may be able to use this data to shape and inform their response when a woman is found to be using substances during her pregnancy. Perhaps they'll shift from an approach of punishment to one of supportive care and intervention for the substance use. Finally, the impact for and importance for women in East Texas and the future generations that they will birth cannot be understated. Here you'll see my references and citations for this, and I would welcome any questions from our audience. But I'll start with my committee members.
Okay, thank you, Andy. That was a wonderful presentation. I just want to check here with our Zoom audience. It looks like still just one person is logged in. I'm going to stop the screen share. However, we might be asking questions about a particular slide, and that's fine. So anyone can ask Andy questions about his research idea. But primarily the committee will probably have quite a few questions. So I am going to ask Dr. Parmentier first to see if you have any questions for Andy.
Okay, one question that I thought of is you are going to include prescription drug use. So how will you differentiate between usual use and misuse of that? And so first, how will you differentiate the two of those?
Me now? Let me clarify. Were you talking about over the counter or prescription? So this is really based on self-reporting. So I'll be asking the women using the substance use list, was there a time when you were using using prescription medications in a way that was not prescribed to you? So I think that the primary way that I may find that people self-report that is that they were using someone else's. For instance, they were using a partner or spouse's or friend's Xanax to treat anxiety during their pregnancy, or that they overtook certain depression medications when things got difficult during their pregnancy. But I don't have a clinical way of measuring exactly what the intake was outside of self-reported.
Okay. So if individuals are using prescription drugs normally, will you be collecting that? So it is prescribed from someone, they're using it as prescribed. Will you be collecting that as well?
Yes, I will be asking about all substances used during pregnancy, including an assessment of the over-the-counter, did they use analgesics to treat pain, such as ibuprofen, Aleve, Advil, because I think that all substances that the woman is using are significant, especially when we start adding in other especially the illegal substances and alcohol and tobacco, things like that.
So are you in your questions going to differentiate between if prescription drugs used normally has any impact on whether they seek care? So how will you differentiate between if they say, I did not seek care to my substance use, we would expect that it would probably not be due to their regular prescription drugs. So how will you differentiate between if any of the substances led them to seek or not seek prenatal care? Does that make sense?
Yes. So in my qualitative section, I have questions about, did you seek prenatal care? And what was your experience? Did you experience any barriers? And did any of your substance use inform the or affect your access to prenatal care? I wish I could quote that exactly for you, but substantively, there is a question and actually a few questions about that.
or anyone else. So I'm going to go back. I want to piggyback on her first question. It's with defining who these women are. So, and it also deals with these acronyms. You have a lot of acronyms. So SUPD, is that right? Or SUDP? Okay, so my impression was from the presentation, the D there stands for the drug. My impression is that these women had to be diagnosed by a doctor, medical professional, as a drug user. But
It may not be. You have to turn yours off and then mine. Yeah. It's one at a time here. So substance use disorder is a clinically diagnosable condition, which is SUD. And then what I'm studying is substance use during pregnancy, SUDP. It's a little bit confusing there because the acronyms are so close together. But I am interested in learning more about women who use any type of substances. Certainly a woman who is misusing over-the-counter drugs may not qualify for substance use disorder diagnosis, along with a woman who's smoking cigarettes very well may not qualify as someone with a substance use disorder, but she is a woman who is introducing substances into her body, so she would qualify for this study.
great, thank you. How close do we get to alternative medicines or supplementary herbal treatments and that type of thing? I mean, and it could be confusing for the woman also. What are we talking about here when we talk about substance use or substance abuse?
Yes, that is something that I did bypass, along with things like caffeine, which is a significant substance that certainly could play a role in pregnancy outcomes, but I chose a limited list of substances as reflected in the substance use poster and my recruitment flyers to be something like tobacco, alcohol, vaping, and then prescription over-the-counter medications. I would welcome any feedback from the participants during our interviews if they said, well, I've been using essential oils or some other type of alternative medicines or supplements during their pregnancy, but I don't have any particular questions developed to measure that.
Okay, and this is just, I'm unfamiliar with this. Do you have any licenses or any of your previous jobs or current jobs that would require you to report mothers who currently have kids in their home and they're using substances currently?
I don't have any active licenses. I will say that all adult persons are mandated reporters, though we don't have the same, I don't have the same legal liability if I don't report something that someone with a license would. However, I think that part of the reason why I've chosen only to interview adult women who have already given birth is that their substance use admissions would not be tied to having a child in their care. So a woman can say, I did use these substances, or I do use these substances on a weekly basis, daily basis, however that comes out in the TAPS tool. But I will not be asking whether she is providing supervision for a child alone in her care during those times, just to avoid any potential liability for having to report anything.
Okay, great. Thank you. And then because you'll be working with you've got a couple hour interview and you'll establish rapport with them. What would you do if a mother expresses interest, if she's currently using an interest in quitting? What would be your response, or do you have any resources?
At this time, I have not developed a resource list, but I certainly will have one and need to have one, not only for someone who expresses an interest in recovery resources, but also a woman who I have any concern about relapsing, or that I have concern that I may have triggered through some of the lines of questioning. I will be providing a local resource list to every participant in case they have any need for ongoing services or intervention well beyond what I can give them.
Okay, great. Thank you.
Oh, am I on? Okay. So for your interviews that you're going to be doing, do you have like locations that you choose? Or are you doing it more on like the convenience of the mother and where and when she can do it?
Can you hear me? Okay. So I will, my hope is that based on where the participants see the flyer, that there may be some access to meeting space in their third environment. So this would be not their home, not their work, but if they're involved in Alcoholics Anonymous, Narcotics Anonymous, a CPS case, or some other organization where they see the flyer, that I'll be able to use a space in their environment where they're already comfortable. Barring that, I do have the UT Tyler campus available, along with a few other public locations or nonprofit centers. And I think that I would have to do that on a case-by-case basis. That's a part of limiting the study to 20 interviews so that I'm not trying to coordinate more than 20 significant length interviews at probably different places. So I don't have a set list for where the interviews will happen because I want the woman to have first choice on where she would feel comfortable doing these interviews so that we can build the best rapport and have the most honest conversations. Okay. Yes, so her question was, is it just a one-time interview? And yes, it is. I'll get to your question. I see that, Musharraf. It is just a single interview time. I don't plan to do any follow-up after the fact because this is a retrospective study looking back on her pregnancy. I don't have any plans to look forward into her early motherhood or continued early childhood period of substance use. And I see we've got a question here from Musharraf in the chat. Do you need to have a non-disclosure document or something on those lines to assure these people that anything they say will be completely private and they will not be held liable for their answers? That's a great question. And I believe that my consent form will cover some of that I'm developing with the IRB. However, I cannot fully promise and guarantee any participant that I will not make a report to CPS. That is because of my obligation as an adult person, that if I am told that and through a qualitative response to a question, that a woman says, well, I grew up being beaten and locked in a closet, and so I do the same thing with my child. I certainly cannot say, okay, well, if I was someone else, I would report that, because I am legally mandated to report suspected abuse to CPS. Now, it is not my intention from the outset to make any reports other than the final report on all the data that I collect. However, I appreciate your question there, but I cannot promise them, I can't promise anyone that I wouldn't report suspected abuse or neglect from these interviews especially.
Okay, so I tend to use the word addiction very loosely. Why have you decided not to use addiction instead of whatever term you use now?
It's a good question, because it is certainly, a good portion of my references did use addiction terminology. But I think that there's an important distinction to be made wherein humanizing the people who are using substances as individuals who use substances rather than addicts helps us to ensure that they are receiving the individualized attention and response that they deserve or should have, or that it would be more effective for them. So to use addiction terminology, as I said, that's a self-prescribed or self-described diagnosis, wherein someone deciding I am an addict leads to better outcomes than someone saying, well, you're addicted to this thing or that thing. That can poorly and negatively impact their willingness to seek care or seek treatment for any issues. So I would not say that any person is wrong for using that terminology, but for the purposes of this study, really to build rapport and show respect to the participants, I think it's important that I not use addiction terminology.
Thank you. We all are. So I'm not sure if this would come up, but what if you have someone who contacts you and said that they were pregnant, but they had a miscarriage or something? Would they qualify for this study or not?
This is a great question. I would say primarily no, because my intentions are to be able to determine if their substance use caused any poor pregnancy outcomes. So that would be measured as something like the neonatal abstinence syndrome or withdrawal symptoms seen in newborns. I don't know that I could confidently say, unless she said, well, my doctor told me that because I drank too much, my fetus did not survive. Unless they had that type of information, I could not say, yes, this substance use truly contributed to the loss of pregnancy, because there's so many different reasons and circumstances that could lead to the loss of a pregnancy. So I would say no, I would politely decline that participant's interest in the study in favor of someone who did have a successful birth outcome, whether or not there were other issues in that birth.
Okay, great. Thank you. And then one more about your exclusion criteria. You say significant mental health problems that are diagnosed that don't allow them to comprehend the study's process. What is an example of a mental health disorder you're thinking of there? And how will you determine that?
Like with many of the other criteria, that would be something that would be self-diagnosed. So if a woman contacts me with an interest for the study and then says, but I have severe anxiety and I might not be able to answer any questions on the day of the interview, or that she says, well, I have severe depression that, when I talk about this, I end up wanting to hurt myself or hurt others. Any indications that the interview would not be safe for participants will lead to an exclusion criteria being enacted so that I can make sure to and protect all the participants in this study.
Okay, so you don't have, when someone contacts you, a list of mental health disorders like, oh, hey, do you have bipolar disorder? You are excluded.
I mean, there's a delay, and
I think I'll end it with I don't know if I have a comment or a question, but let's see how this plays out. So it sounds like these women have to contact you so that you can make an appointment to interview them. So I sense there's some kind of bias there. We'll just think about that for a while. But I also want you to be prepared. I think you'll go into a WIC office and the receptionist will say, I got two women right here. So I think you have to be prepared to interview on the fly immediately. And that might actually be your best selection strategy, though I don't know. And I don't have a question to tack on to that.
I will tell you that even just yesterday, I went to get a haircut, and the stylist who was doing my hair, I was just talking about today's presentation and my thesis topic, and the stylist in the stall next to me said, oh, I know two people who are using drugs right now and they're pregnant. They should be delivering in the next month or so. Do you want their names and phone numbers? And I said, oh, no, not quite yet. Got a little bit more time to go, but I think that there is a hunger and desire for the women who are using substances during their pregnancy. They want their voice heard. And I think that I certainly will have to be ready on the fly to be able to conduct these interviews because women want their voices heard. Sure, there's a $25 gift card in it for participants just to thank them for their time. But more important than that will be the dissemination and sharing of the real life experiences of the participants of this study. And I think that that's going to go a long way.
What if you have two women who are like, we want to do the interview? Will you then turn it to a focus group, or will it become like just the interview? So one will have to wait till the other one's done. Like they both want to do it at the same time in that case.
That is a great question that I have not considered up to this point, because in my mind it has all been the kind of the snowball where an individual person would refer a friend. I have not considered the possibility of conducting dual interviews concurrently. I think that my interview tool would I think except for section 2 of my interview tool, I could easily incorporate a dual interview model. But the TAPS tool is reflective of current and recent use from the past 3 months and the past week, things like that. And there are significant, so I'm afraid that I might have biased answers based on the presence of a friend who knows when or how often that individual has been caring for their child or has been at someone else's home, things like that. I'm afraid that I might have some bias in the answers that I get from that part of the interview tool, but I certainly, depending on the logistics of the interview area, meeting room, things like that, I could probably conduct most of the interview together, because I think every other part of the interview would allow for multi-participant concurrent interviews to happen, and then split participants for that one assessment during the interview, though I have not, clearly have not thought through that quite yet. Yes, thank you.